Well, hello everyone. This is Dr. Isabelle Amigues, your friendly rheumatologist, and it's always such a pleasure to be here. And I am going live, and today we are going to discuss what reactive arthritis is. I'm sorry. So it's actually quite important to know about this, and I've seen more and more. This is the time where we are starting to get quite a bit of infection out there, and basically it's one of those conditions that often shows up quietly. It doesn't really follow the usual rules. And a lot of people are feeling really confused or even dismissed when it comes to reactive arthritis. So if you have noticed joint pain or inflammation after being sick, that might actually help you, and it's going to help you put some pieces together. And that's really what the goal is of today's live. If you're watching this live, please put an hashtag live. If you're watching this as a replay, push at hashtag replay. It does help us increase the reach of this video. And as always, those videos are meant to educate you. I'm a rheumatologist. I have done 2 trainings, one in France, one in the US. And so the goal is to put an educational content on social media that is of value to all of you. All right. So what is reactive arthritis really? What is it? So it's a very interesting arthritis because it has been triggered by an infection, but it's not an infectious arthritis. So what I mean by that is that some people can actually develop an infectious arthritis. So if you have, so sometimes if you have had, for example, like a knee replacement or replacement of a joint, and then there is a bacteria that goes into that knee or any other joint, that's an infectious arthritis. You can have an infectious arthritis that has nothing to do with a replacement of the joint, but it's usually one joint, okay? When you have an reactive arthritis, there is no infection per se in those joints. It's a reaction to an infection. Very often that infection happened before. So you may have had an infection, you have recovered from that infection, and you develop that reactive arthritis, which is basically your body reacting to the previous infection. But that reaction may actually stay even after the infection. And it's basically your immune system that hasn't fully reset, right? There's an inflammation that occurred after the infection. That inflammation is not fully reset, even though you have treated the infection. So what's really interesting, like important for me to say, is that it's not that it's your body attacking itself. It's not random. It's literally your body thinking that it needs to create an inflammation to get rid of this infection. It doesn't know that this infection has gone away. And so the job of the rheumatologist, and our job, is going to be to rebalance your immune system so that it goes back into an equilibrium, a balance, because that's where you need to be, okay? So how does it usually shows up? So although some people would be like, oh, it's just like this or that, and it's complex, it's not complex, right? So you're going to develop some joint pain that's inflammatory. So what's inflammatory arthritis? It's worse in the morning. It's associated with morning stiffness. You feel stiff. You feel like you need to put some oil in your thin joint, right? And after, 30 minutes, 1 hour, I have some patients, several hours, you finally feel loosened up. Well, okay, that's an inflammatory arthritis. If there is swelling of the joint, that's an inflammatory arthritis. So you may have an inflammatory arthritis. You may have noticed some tendon pain. So you're like, it's not the joint, it's the tendon, right? And maybe it's the heel, the Achilles tendon, the heel. Maybe you suddenly realize you have a lot of lower back or pelvic pain, like the sit bones are hurting. You can also have inflammation of the eyes, or like blurry eyesight, like when you're looking, you're like, I have blurry vision now, or maybe it's like red, or maybe it's very painful. You may also develop urinary or genital symptoms where when you're peeing, it's very painful. And then finally, you can have some fatigue or feeling off. And it's not necessarily easy to describe, but you're like, I'm feeling off. This is odd. And then I have this joint pain or this eye inflammation or so on. Okay. It doesn't show up as one thing. It's usually 2 or 3 or more things. It's not just joint pain. It's not just eye inflammation. It's not just inflammation of your urinary tract. It's usually like all of it together, right? Like, and not all, but like some of it together. And it's very often missed. So one of the things that's important is to realize that it's not an easy diagnosis. Why? One, because the infection may have actually occurred weeks earlier, right? So you didn't even put it together until you come to the rheumatologist and we ask you, have you had an infection? And you're like, oh, yeah, I had some antibiotics the other day, and you don't actually put this together, right? Or maybe you had some diarrhea, but you don't put it together because the diarrhea was like maybe several weeks ago. And that's actually really interesting. Like in young and especially men, in young men, it might be a sexually transmitted infection, STI, but again, they've taken care of it. And so we don't actually put it together. And so that's actually what's important, is that the joint pain you have, the first question, is it inflammatory? The second question I'm very often asked is, do you have back pain that's inflammatory also? Worse in the morning, associated with morning stiffness. And then third is, was there an infection in the past, right? Like, has there been an infection in the past, I don't know, like I want to say like a month, 2 months, right? And the reason I go all the way to 2 months is that the joint pain may not have been that bad at first. So you think that it's only been a month that you have this joint pain, but really it was before, it had started before. So the way as a rheumatologist, I think about this is that very often it's if the pain is one asymmetric, so it's not all the joints are not like being involved, or like it's not both hands or both knees, but it's like one, like some joints on your hand, on one hand, some other joints on a knee, some joints on a heel, and it looks like a spondylo, so spine arthros joint pathy disease, right? A spondyloarthropathy affects the back or the torso, like, right, the joints in the back and the joints of your torso, the musculoskeletal, so costochondritis. And when there is that, I think a spondyloarthritis, because reactive arthritis is part of this family. And that family is a HLA-B27, most of the time positive, which is like a gene that we carry. And so if you are HLA-B27, you're more at risk to develop a spondyloarthropathy, but it doesn't mean you're going to develop it. And so when someone presents with something that looks like reactive arthritis, we are going to order the HLA-B27. And so the idea is like, do you have an inflammatory arthritis? Does it involve the tendon, the heels? Does it involve the back, the torso? If that's the case, then you're like, okay, that could be a spondyloarthropathy. And if there has been an infection not so long ago, could it be reactive arthritis? Okay. So the diagnosis is really more like a clinical diagnosis. And then you have tests that can help you make the diagnosis by checking your HLA-B27. You can also check to see if there's still ongoing bacteria, but that doesn't mean it's going to be there forever. Okay. So that's actually, I think, is very important. And so if you don't have a bacteria or an infection going on, it doesn't mean that it's not reactive arthritis. So the clinical diagnosis is where we are making the diagnosis. The tests, they just help us. So for reactive arthritis, 80% about of patients are going to be positive for HLA-B27, but not everyone is, right? 20% are not. And also, it's not because you have HLA-B27 positive that you have a reactive arthritis or a spondyloarthritis. So that's actually, where there is that subtlety. And again, clinically, that's the most important, the most important thing is the clinical presentation, okay? Again, The most important is the patient's timeline. Like, what is your story? That's like the most important. So the good news about those is that the treatment and recovery perspective, most of the time you recover kind of just with NSAID, so ibuprofen, naproxen, diclofenac, maybe you have taken Advil, Aleve. Usually that's enough, right? Some patients will need something called a DMARD, so disease-modifying anti-rheumatologic drugs, such as methotrexate, sulfasalazine. But the truth is that if you have an involvement of the back, we actually go to a biologic with TNF inhibitor, for example, directly. So what I want to say here is to realize we have treatment. And the other thing, and that's something that I tell my patients, is that yes, you may need treatment, but that doesn't mean you're going to need it forever. And so we might start with treatment and then back off, right? The goal is to take care of the inflammation, get you in remission as fast as possible, and then back off. So the goal at first is calming the inflammation. It's kind of like this fire, put off the fire. Support movement. You don't want to restrict the movement, but at the same time, you want to be gentle. You want to address any ongoing triggers. I used to have a patient that had a couple recurrent UTIs, and it would develop basically those reactive arthritis bouts. And so by treating the infection, by making sure we prevented those infections, we actually were able to prevent the reactive arthritis. And then realize that everyone is different. Some people are going to recover from their reactive arthritis right away. They don't even need anything other than NSAID. Some other people, it's going to be more of a journey. And here's the thing that's of importance is that what I find is that very often, if you really look into it, some patients think that that's the first time they had joint pain, but really when you're actually like asked, they have had back pain for much longer time, except that the back pain responded to movement, responded to ibuprofen, for example, and they didn't actually put together the fact that the episode of reactive arthritis is just another form of this inflammatory back pain they've had. Those patients, they may need medication more so than those other ones, because that reactive arthritis piece is happening in the context of this inflammatory back pain that has been there for a much longer time. And so they might have a spondyloarthritis that we need to take care of, okay? So again, when do you want to consider this pattern? So when you have joint pain or tendon pain after GI illness, so like food poisoning, after urinary infection, after a sexually transmitted infection, okay? If you feel like you have symptoms that look like as if you had an injury, but you know that you haven't had an injury, you want to think about that. And then if you have pain that's fluctuating in time and not improving steadily, you want to think about that, okay? So again, this is all for you to understand how this, is looking and how this approach. But realize that your body is here to heal you. And that if your body is not healing you, I don't see personally as a rheumatologist the point of waiting. And personally, if you have a fire, put out the fire as fast as possible, then you can back off, right? It is important for you to reach out to a rheumatologist if you realize that this is not going to go away. This is not going away even with NSAID, because we have other treatments. And as always, if you are living in Colorado, I would be happy to help you reach remission. So hopefully this has been helpful. I'm seeing like a lot of light here, but if you find this helpful, please share this with another friend, maybe that has been that is helping, like that this helps with. And then if you are interested and need to see a rheumatologist and are in Colorado, please come and check out On a Bridge MD. And with that said, thank you so much for being here. Some of the comments here. Hi, Clea, it's always a pleasure. Christophe, thank you so much for telling me that I don't have an accent. I know I do have an accent, I'm French. And as always, it's always a pleasure. Hi, Nicole, it's always a pleasure to see you. And Shelly, it's always a pleasure to see you. So without further ado, have a wonderful week. I will see you next week, and it's always a pleasure. Take care. Bye-bye.